The word Kaizen is typically translated using the two characters, Kai meaning change. Now there's a lot of need for change in healthcare. There's always a lot of change initiatives going on in the industry. And then we have the word Zen, which means good. So the word Kaizen gets translated usually in the context of change for the better. Not all changes necessarily are improvements. You know, if changes are being forced at people or if there are outside solutions that really don't address our core problems, not all changes are necessarily improvements. But in Kaizen, they're changes for the better. And this word is used normally in the context as introduced by Masaki Imai to the Western world some 25 years ago in the context of continuous improvement. Now, two things I'm going to talk about today are so-called Kaizen events, week-long events. Not a bad thing, but I'm going to argue that Kaizen event is a horrible misnomer, that we'd like to maybe put that term back in the can if we could. And then I'll also talk about some, if you will, modern methods for engaging people in continuous improvement that are different than the old traditional suggestion box and why that approach doesn't work. So those are some of the two key themes for today, moving beyond just events and moving beyond the suggestion box to really make continuous improvement and Kaizen an everyday occurrence and part of our culture. Now, we owe a lot of gratitude to Mr. Imai. His book, Kaizen, was published in the West in 1986, 25 years ago now. And a lot of these Kaizen ideas build upon lessons that come from North America and Europe. Dr. W. Edwards Deming, of course, being an American who was greatly influential, and a lot of his ideas and concepts are part of what we would recognize as Kaizen, as part of the lean methodology. But I think one way Kaizen is different, at least in this last trip across the ocean from Japan to the U.S., is this slight, this infusion of Eastern culture, if you will. And Mr. Imai made the point, and I think this is still very true today, and it points to where sometimes organizations struggle with improvement efforts. In the West, Mr. Imai wrote that the focus has always been on ROI. And I hear this when we talk to people in healthcare organizations. You have people say, well, we can only make changes if we can demonstrate or really predict ROI, return on investment. And that can be really limiting. And I'll share some data at the end of the presentation about the impact and even the financial impact that we can have from Kaizen. But as Mr. Imai points out, and this is what we're seeing happen today with Kaizen in healthcare organizations, the focus is really, and especially initially early on staff morale and engagement. That we do Kaizen to engage people in improvement, to build their enthusiasm in the workplace and their enthusiasm for improvement. We let them focus on quality, patient safety, making their own work easier, and then as a happy end result, we tend to get cost reduction or other financial impact. So we get financial impact in Kaizen as an end result of doing all of these other things well, not strictly focusing on cost or ROI. This frees people up to think about all sorts of improvements, and especially little improvements that can make a huge difference through Kaizen. So Mr. Imai published his book in 1986. And maybe not surprisingly to those who know Dr. Don Berwick, was, as usual, on the forefront of quality and improvement activities. Dr. Berwick published in 1989 in the New England Journal of Medicine an article titled Continuous Improvement as an Ideal in Healthcare. And Dr. Berwick cited Mr. Imai's book, Kaizen. He used the term Kaizen and talked about what a great need there was for this in healthcare, describing Kaizen as the continuous search for opportunities for all processes to get better. Now, Dr. Berwick was writing about this 20-some years ago, and I think today, here in 2011, going into 2012, healthcare leaders are still looking for a continuous improvement culture. They're still trying to figure out how to make that happen. And I think part of the reason why that might not be there is that we really haven't fully embraced the ideas from Dr. Berwick, Mr. Imai, Dr. Deming, and others who came before them. So if we've got leaders in healthcare, national leaders, international luminaries talking about the need for change in healthcare, we have people in hospitals who are often quite frustrated with how things work or don't work today. They want change. They want things to be better for their patients and for themselves and for their organization. But one thing we often hear, anyway, is some variation of this expression, this idea of say, well, yeah, this Kaizen stuff makes sense, but you have to understand, my people hate change. And often that statement gets used without stepping back to kind of question it and say, well, time out, wait a minute, is that really true? Do your people hate change? I mean, some people expand upon this to talk about all of humanity and say, oh yeah, people hate change. And I think that's an important moment to step back and say, is that really true? Are there just certain times when people hate change? When I give this talk in front of audiences, people often say, oh yeah, people hate change when it's forced on them. And I think that's a big part, that's an important lesson of Kaizen. And to step back and look at what management experts like the late, great Peter Schultes said. This was a big light bulb moment for me when I read Dr. Schultes saying, people don't resist change, they resist being changed. And I think that's really important, that when we allow people to identify and initiate and actually implement their own ideas for improvement, I think we find people don't hate change. In fact, they're quite enthusiastic about it. So we need to figure out how to engage people in that change. So if we look back, this has been true in manufacturing, and I think this has been true in healthcare the last 10 years. The word Kaizen often gets associated with a concept called the Kaizen event or the Kaizen blitz. And what they mean by this is, typically a week-long improvement event that's somewhat episodic. We might do a couple events a month, a couple events a year. It's got a defined scope. It's really more of like a mini project. And events are good things. There are a lot of organizations that have gotten great results from their events. But I say, well, really, is that the only way we can do Kaizen? If Kaizen is supposed to be continuous, what can we do in addition to these week-long mini projects or these week-long events? Now, there's another Japanese word you run across less often than Kaizen, this word kaikaku, which can be translated as radical change. And I think these week-long events, they're often called, for example, at ThedaCare, a rapid improvement event. Virginia Mason Medical Center and others will call them rapid process improvement workshops. I think those are more accurate and better names. I really don't expect anyone to start calling them kaikaku events any more than I expect the term Kaizen event to go away. But I think RIEs are important, but in some ways they can be problematic. And as you see on this next slide, Virginia Mason has been working with Lean for 10 years, and they've done great things for their patients and their staff. A lot of the attention of what they've done with Lean has been focused on their RPIWs or their events. And even at one of the top Lean healthcare organizations, as one of their former leaders published, this is going back to 2005, they were only holding the gains on about 40% of those changes because it was too easy to slip back into old ways of doing things. Now, I think some of this is maybe just, you might say, okay, well, the events weren't run properly or there wasn't good follow-up. I think some of this problem, though, is just kind of somewhat inherent in doing a week-long event. And I think in healthcare, when you have 24/7 departments, lots of people working different shifts, different days, I think it's somewhat unrealistic to think, well, we're going to really fully engage everybody and implement a brand new process or a greatly modified process in a day and say that we're done. And now all we have to do is sustain. I think this is sometimes unrealistic in healthcare because we don't have everybody there necessarily at the same time. But I think, used in the right context, events can be very powerful, but not every change needs to be an event. And we can use true daily continuous improvement, daily Kaizen, to help sustain or really continually improve after a week-long event. Or there's a lot of cases where we can use small daily continuous improvement in lieu of an event, because not every problem or opportunity needs a week-long event to be able to solve it. And so, to me, week-long events or Six Sigma projects are part of this broader landscape of what Toyota calls different levels of Kaizen, is illustrated here. You might have a small number of really large systemic issues. You're building a new building, you're putting in a new electronic medical record system. organization can only take on one or two of those at a time maybe. And then you've got this middle band, a greater number of medium scope problems that do lend themselves very well to a week-long event or a Six Sigma project. But then at the bottom, you've got all of the little small pebbles and tiny rocks, the little small daily issues that can either be addressed in more of a quote-unquote just do it mode, or from something significantly smaller than a week-long event. And I think what we're seeing in leading organizations, Virginia Mason does week-long workshops, but they've also had a program going on nearly as long focused on daily continuous Kaizen. If you look at ThedaCare in Wisconsin, they started with week-long events and did amazing things with those events, but then after a couple of years they realized there's something missing, and that's where they started embracing what they call CDI, or continuous daily improvement. And in fact, over time, some of the balance has shifted where they estimate and project that 80% of their improvement comes from that small, locally driven, staff-driven improvement, not from the rapid improvement events. So regardless of whether you start with events and move to daily Kaizen, there's another organization we feature on our book that started with little small daily Kaizen and then worked their way up to running week-long events as people kind of gained confidence in their ability to change. One reason all of these different types of Kaizen or types of improvement fit together is that they're all built on the PDCA or the PDSA model. So this is the Deming cycle, or as he would have called, Dr. Deming would have called it, the Schuhart cycle, basically following the scientific method of kind of plan, identify a problem, come up with hypotheses for change, consider different alternatives, then we do and we implement one of those changes. But then we study the impact of that change. And so, well, are we getting the results we expected? What do we learn from that? Then do we move forward, or do we go back and try something else? So whether it's a week-long event or small daily continuous improvement, it's really that same mindset. And by learning one type of improvement, you can go and do the other because it's the same mindset, maybe a different scale, size of problems. So when I step back to wanting to make Kaizen part of our culture, looking at Toyota as an ideal or an example of a continuous improvement culture, there's a Toyotaism that says, everybody in the company has two jobs: to do work and to improve your work. As Mr. MI would say, whether you're the janitor or the CEO, everybody can be involved in improving their work. And I think this is a powerful statement. This was on Toyota's website a while back, on their corporate website, under the banner of what sets us apart. And you see here, that every Toyota team member has the ability to improve their work environment. So this doesn't mean that, for example, in a hospital, that we're expecting frontline nurses to solve all of the big, huge systemic problems on their own. Senior leaders aren't just dumping this on their frontline staff. They're working together. But when you can make local improvements in your own space, then that becomes, as Toyota calls it, the cornerstone of an organization's success. Toyota said it's their improvements and their suggestions. So they don't talk about their technology or their factories or their robots or any of that. It's their employees that are the cornerstone of their success, and we're starting to see more of that in healthcare. Now, I was doing this workshop once in a hospital, and somebody came up and actually said, well, here, let me show you how it is in our hospital. And they drew a variation of this diagram on the easel pad, and they said, look, this is how it is in our hospital. The focus is on do work, and then a very small focus on improving work. And so we look in healthcare and say, well, why don't we have more Kaizen? Some of it's just kind of the cultural expectation that people just come and do their individual work clinically well, but we're not looking at systems and processes and all the interaction. And I think oftentimes hospitals aren't making the time. They're not allowing people to make the time. We're sending people home when census is low, instead of engaging them, using that time for Kaizen or continuous improvement. So if we're convinced that Kaizen and continuous improvement is an ideal for healthcare and something that we want to go implement, you'd say, well, how do we go make that happen? Take it from the conceptual to the practical realm. And you might say, oh, we've got suggestion boxes. But as I've illustrated here, I would argue that the suggestion box and the way suggestion boxes are typically used really run counter to everything we would consider to be a Kaizen concept. One thing, look at the box, you can see it's got this lock in the front of the box. And I would challenge you, I did a blog post on this a while back, it's really, really difficult to go shopping online and buy a suggestion box that doesn't have a lock. It's like they've assumed that that's a feature that you just absolutely must have. You step back and say, well, why is there a lock? Or are we afraid that employees from a competing hospital are coming in and stealing our suggestions? I think that's not usually the case. What people often point out is that, well, suggestion boxes attract anonymous complaints about other employees, and now that's an HR issue. And, well, yeah, we can't let people see what's in the suggestion box. So often what happens is with that locked box, it's not being checked very frequently. In fact, there's one hospital I worked with, and I think it's the box that we took a picture of right here. Somebody went off to go find the key because we want to say, well, let's see what's in that suggestion box. And the staff member went and looked for 20 minutes, and she came back, and they couldn't find the key. And so we kind of ceremonially, tore open, half smashed open the box and said, okay, this isn't working. So what are some of the dysfunctions with suggestion boxes? And again, I think on some level they're well intended, but they're just not, they're not facilitated using lean principles. So some of the dysfunctions is that suggestion boxes tend to be slow. I mean, it's a batch improvement process. If a manager comes and checks the box even once a week, that's slow, or once a month, or once a quarter. A lot of times, suggestions basically just get voted yes or no by a committee or a group of managers that might meet monthly or quarterly. They're not interacting with the person who had the idea, so they're just reading a card or a slip of paper and saying yes or no without actually going to the Gemba, as we would say, go to where that person works, look at the problem they've identified firsthand, and collaborate and work back and forth to find something they can implement. So suggestion boxes tend to be not very collaborative, not transparent. People don't know the status of their idea, or if it's been rejected, they often don't find out why. And suggestion boxes often focus on things that we want you to buy me instead of things that we can do to improve our process. So I'm going to show an alternative model that I think gets past some of these dysfunctions and allows us to facilitate Kaizen in a way that is collaborative and is visual and focused more on process improvement. So I mentioned Misaki and I. We also, Joe and I as co-authors, owe a lot of debt to Norman Bodak, who's written a lot of books about Kaizen and continuous improvement. And one key point that I've taken away from Norman is the idea, as he puts it, that suggestions are things that I think you should do, whereas ideas are things that I can do. And that's one reason I tend to like to call these idea systems as opposed to calling them suggestion systems. That the idea is that your idea is something that you maintain ownership of and that you can go and implement and put in place. And so let me show you an example, and we'll talk through more of the process here. This is what my co-author's organization, Franciscan St. Francis, calls a quick and easy Kaizen report. So this is just a simple visual summary. It's not even anywhere near the complexity of an A3 because it's not that complex of a situation. But it's a simple before and after illustration that, as you see here, defines a problem. The before statement is that little patients wouldn't lay still for ultrasounds. This would frustrate parents, and the kids were stressed out, and that would stress out staff. And arguably, from a clinical standpoint, if kids are squirming around, because getting an ultrasound's kind of icky with that gel that they use, you're not going to get a good quality ultrasound if the kid's moving around. And so Hope, who wrote up this Kaizen, you see Hope pictured here, she had been at a wedding one weekend and had one of these little small bottles of bubbles in her bag, and she had a brainstorm one day and said, well, wait a minute, I wonder what would happen if I blew bubbles. And in fact, this is something that's used at other hospitals as a way of calming children. And as you see documented in the after condition, that's a pretty happy looking baby reaching for the bubbles, and in fact that's a mother who's participating in blowing the bubbles there. So we have the before, we have a problem. After, we have a countermeasure, let's try bubbles. What was the effect? Happy babies, happy parents, happy staff. Arguably, good clinical performance, maybe better throughput if kids aren't delaying their procedure because they won't lay still. So this is documented and shared throughout the organization, and you see in the bottom right where it says estimated cost savings, it says optional. It would be really hard maybe to calculate an isolated ROI for this improvement, but they don't let that hold them up in the organization. They go and do it because it's the right thing to do, and they document it and they share it and they celebrate it using this format of the quick and easy Kaizen report. So let's talk about the process that they use for getting these ideas identified and implemented. So you look at Kaizen, daily Kaizen is a 5-step process, and we'll walk through these. Finding ideas and then discussing them with the supervisor. So we don't have people just working in isolation. They're working with their team and with their manager. They're discussing ideas briefly in a non-bureaucratic way. They're implementing ideas. They're testing them through the PDSA cycle. Then they're documenting and sharing them through their organization, through their department, and beyond. And so when we talk about seeing and finding problems, this can be a big cultural challenge, helping people to really see waste where before they might have seen a lot of motion and activity and workarounds. So this is something I've heard described as problem awareness. First off, being able to admit that we have problems. This comes back to the Toyotaism of saying no problems is a problem. We need to be, kind of psychologically ready to say, we have problems and we're okay, as long as we're working on fixing those problems. And then I think the second part is teaching people some lean concepts, like the notions of waste, teaching them lean thinking, kind of helping shift the culture so that people, instead of just going through workarounds every single day, are now identifying that as a problem that they can fix instead of just dealing with that problem every single day. So we have to be able to admit we have problems, be able to see problems in the workplace. Now Henry Ford, this is going back almost 100 years, so arguably an early Kaizen thinker who was highly influential on Toyota and other companies. Henry Ford once wrote, "There are no big problems, there's just lots of little problems." And so a lot of times when we're talking to hospital staff or managers or leaders about identifying opportunities, sometimes people kind of freeze up and they say, well, I don't have any ideas, because they're looking for maybe that one big, huge $1 million idea that's often asked for and celebrated. With Kaizen, we want to kind of help get past some of those barriers to change by focusing on lots of little problems. We can identify those in the workplace and asking people not to save a ton of money, but to help identify things that would make their own job easier. That might seem selfish, but like in healthcare, if a nurse saves time that they can dedicate to patient care, that's not really selfish at all. We can apply that saved time in a good way. Save a few seconds here or there. Ideas that improve patient care or service, improve safety, reduce waiting time. And I'll show you some examples from different organizations of some Kaizens that fall into those different categories. So we want to get the ball rolling with lots of little ideas, and before you know it, people will move on to identifying bigger challenges and bigger, more systemic improvements. Now one example, this is one of my favorite examples of helping clinicians and healthcare professionals see waste in their daily work. So what you see here is a spaghetti diagram of a podiatrist at a clinic in Illinois. So all of the red is not his walking in motion for the day. This was all of the walking for just a single patient. Walking from the exam room, this is just a simple toenail procedure, but the poor doc was having to run to the lab, the procedure room, his office, and back and forth, and he's searching for things, as we see pictured here: gauze, scalpels, freeze spray. Now part of the problem, and it's not that he was forgetful, but he worked in 4 different clinics, 4 different days of the week. So he would forget. If it's Tuesday, stuff must be stored in this room versus that room. Things weren't standardized across the 4 clinics. So this is wasting his valuable time searching for stuff. It's delaying the patient and wasting their time. And when the nurse who shadowed the doctor and did the spaghetti diagram showed it to him, he really looked at it funny. He's like, well, what is that? What do you mean? Like, he really couldn't believe that he had walked that much. And so, to him, that was what you had to do to take care of patients. And it really hadn't been questioned and challenged before. But with lean thinking, you start seeing this as waste and all that running around as a workaround. They could come up with some simple things to fix that situation. And so what the team came up with very quickly was, as you see pictured on the left, they had an empty crash cart that wasn't needed or wasn't used in a primary care setting. They said, well, why don't we make that the Dr. Serpy cart? And they stocked it with everything that he needed to take care of his patients, his little procedures. This is going back a few years. This is before Dr. Gwande's book, The Checklist Manifesto. It just seemed like common sense to the team that they should have a checklist so that the night before Dr. Serpy came in, they could restock the cart, roll it outside of the rooms that he used. And he went from not seeing the problem to his first day of using the cart. Of course, his next question was, how quickly can you get me that same cart at the other 3 clinics? To not just standardize things, but to make his work easier. And this is, to me, a great example of a little small Kaizen. So we want to find problems, and then there's a bit of a cycle where we discuss and implement them with the supervisor or within a team setting. Now, to help capture and document these cards and to trace them through the process, I like to use a format you see here called, you might call it an idea card. Kind of a standardized card that helps prompt people through the PDSA cycle. And this is different. If you look at the traditional cards that you can buy to go with suggestion boxes, it often just says, what's your idea and what's your name? Where here we're trying to prompt people to also come up with a problem statement or define an opportunity, as you see on the card here. So if somebody comes to a supervisor with an idea, I think we should do this, and that idea is maybe not practical or not affordable or can't be done right away, instead of just saying no to that idea, we could step back and say, well, have we really defined the problem? And can we find a different way of addressing that same situation? So this is one of the first ways this becomes much more collaborative instead of just being a yes or no interaction. It's a supervisor kind of helping brainstorm or kicking it back to the team to help them come up with other ideas. And if a staff member has a problem statement, we also want to encourage them to come up with ideas and not just register a complaint. Now, if they don't have an idea, that's fine. We can document the problem and take that to the team and ask them, what ideas do you have to come up with to address that? We want write down the date and the name. Ideally, this wouldn't be an anonymous process. We can prompt the person with the idea to say, well, what are the expected benefits? What's the hypothesis of change? What do we think this is going to impact in a measurable or a qualitative way? Who else do we need input from? Is this another shift, different departments, the chief pathologist in a lab? Most Kaizen improvements can't be done purely individually. We need to go and check with other people. And then the back of the card, as we see here, can be used to document implementation steps if it requires a mini project plan, or sometimes it's to just do it. And then the bottom of the card helps us close the loop on the study and adjust phases of, did we get the results that we expected? If no, that's not the end of the world. We'll learn from that. We'll go and try something else. And if yes, we want to maybe prompt standardizing that method, communicating it. I've seen one organization that has a similar card that kind of prompts and hardwires the recognition that's given after somebody has a completed and implemented Kaizen improvement. So I found a card like this can be very effective, and instead of hiding it in the suggestion box, we can use what I call a visual idea board. And a lot of the concept here comes from David Mann and his book, Creating a Lean Culture. And we've seen this work very effectively in a number of organizations where we now have transparency instead of a closed, locked box. We have 4 columns, and these ideas basically flow from left to right on the board. Brand new ideas would get placed in that first column. Now, these idea cards might be brought to a team meeting where they're discussed verbally and then put up on the board. Sometimes if somebody just catches a manager in the hallway, they talk about it and write up a card and tack it up on the board. Or sometimes people are shy and they just tack it up on the board and run if they don't want to talk about it in front of the team meeting. But there's different ways of facilitating and drawing out these ideas so they get put up there for the team to see. And then we have a column of things that we're going to do. So we maybe had an initial evaluation of the idea. We come up with a plan going forward. And then the third column usually represents, here's the things we're currently working on. And the fourth column are things that are completed. And so there's a bias, and you can see in the labels on the board, we're certainly not saying good ideas, bad ideas. The bias is towards implementing as much as we can and working together to find something that we can implement to address an important problem or opportunity that somebody has identified. Now, looking at this board, we can tell at a glance, unlike a suggestion box, what's the health of our Kaizen program? If we have lots of cards in the left-hand column that aren't moving, basically we know the bottleneck is not in idea generation. And we see lots of cards in the right-hand column, but we're not getting new cards on the left. We know maybe we had a spike of ideas, but this isn't yet a continuous daily process. We can check all kinds of metrics such as the completion time for these ideas, and really kind of whether we're a frontline manager or a senior leader coming through on a Gemba walk, get a good sense of how things are working or not working as we manage and facilitate this Kaizen program through a board like this. So let me show you a few examples. These are real cards. They've been typed up, but these are real cards that have come in from hospitals. These two are from a nursing unit to show you some examples of what frontline staff identified. So you can see there's a problem statement. Combs aren't able to get through female hair, and the idea was we need hairbrushes for the women. Now this meant going and spending a little bit of money. So you can see where it says input needed from. This was the nursing manager and the purchasing manager. Because frontline staff often don't know, how do we get a new item added as a standard stock item in our department. So instead of just fighting with this or giving up, they work with their supervisor and they figure out, here's who we need to talk to. The expected benefits are patient satisfaction. And again, it's really hard to tell what's the ROI of a patient and staff member being happy because they can provide a non-clinical but care and service to a patient. If this is a traditional suggestion box, if it just said we should buy hairbrushes for women, that might get rejected. Where here the problem statement is very patient focused, that this is something that directly impacts our patients. And this got accepted and implemented pretty quickly. Here's another card, one of their early cards that says problem statement. You can see the frustration that comes out. It says, again, too much running around. But the idea said isolation signs could be kept inside isolation boxes, and when a sign is needed, it's right there. So the expected benefit would be infection control because the signs are posted more frequently. But here there was a little bit of discussion with the supervisor and team to ask, well, I don't know if we should really store and reuse those signs and store them in a box with clean, sterile items. So rather than just going and rushing to implement this, they had to talk about it and check and see, is this really the right thing? And if they couldn't do that, the problem statement is a valid one. Either isolation signs don't get used as much as they should or staff are running around too much. The obligation of the supervisor is to help find something that can be implemented rather than just saying no. And here's an example of a completed idea card. This is from a lab phlebotomist. You can see a problem statement. Many patients don't speak English. It's hard to get an interpreter. So the idea is somebody in the team knew somebody in the ED that had a translation phone that they thought, well, maybe we can get one of those to use too. Expected benefits, better communication, better care. Now look at the dates on this. This idea was originated on April 2nd. It was implemented and in use just 2 days later. And that's one of the key points about Kaizen, is that this needs to be a rapid process of improvement. That if people bring you ideas, it's the obligation of leadership to take quick action, not let ideas sit in a box waiting for a monthly review. If they're good ideas, you want to implement them as soon as you can. If they're ideas that aren't practical, again, you work together to find something that can be implemented. So we find the cycle time for the completion of ideas in a system like this tends to be much faster and shorter than a suggestion box because, for one, these cards are out in the open for everybody to see. And employees, in a way, can really kind of help keep their supervisors accountable that you're supposed to be helping us implement these ideas and not just let them sit. Now, there are times, and you have to be cautious about this sometimes, that you need to coach people on their idea cards. Now, you don't want to be discouraging or negative or make people feel bad, but sometimes you see opportunities to kind of coach people through good problem-solving skills. So this is a real card. This is from a hospital lab. You can see it says problem. Pour-off samples have red blood cells in them. This is a problem from a clinical quality standpoint. The idea says basically, well, be careful when pipetting into pour-off tubes. And you might step back and say, well, what is the real root of the problem of why we're getting red blood cells into the tubes? Is it because people aren't careful? Is it because maybe we don't have the right equipment? Is it because people are rushed? Because they're overburdened and they're having to kind of race through their work, and that leads to quality problems. There's all sorts of things we could do maybe that are more effective than, I don't know, hanging a sign that says, be careful, don't get red blood cells in the tubes. So as a supervisor, in a kind of a friendly, gentle way, you can coach and sort of challenge people to help come up with different ideas that might really more effectively solve that problem. Now, I mean, you could let someone run through a PDSA cycle, and if they said, well, let's hang a sign and measure and look at the results, and if quality didn't improve, then okay, fine, we better try something different than a sign and try to find a good improvement that really addresses the problem. Now, the second example, this was a card written by an inpatient unit where it says, problem, admissions from the ER between 5 and 6 while we're doing a report come up and patients might not be seen right away. So the inpatient unit said, well, let's just postpone ER admissions until after 6 when we're done with reports. So this is where, working in collaboration with other departments, you might look and see, well, maybe that's not the most patient-centered thing to just tell them, no, you can't come from the ER. There's a serious problem here. If patients are being brought up and not being seen, what are some different ways that we can address that? Can we reduce the amount of time it takes to do report? Maybe we need a role called an admissions nurse that can focus on patients who have been brought up. So we need to make sure that we don't have a change that sub-optimizes the inpatient unit at the expense of the ED, for example. We want to make sure that as supervisors, we're looking out for things that would otherwise be sub-optimizing. So here's an example of how a new board might progress over time, and you can see how things flow and how this can be visually managed by leaders at different levels. But again, just to touch on the point that the bias needs to be towards finding something to implement. Now, there's different books or articles written about Toyota and their Kaizen process. At the low end, the estimate is that 90% of their employee ideas lead to something being implemented. Now, this doesn't mean the idea as it exactly came in, but they're working together to find something that can be implemented. Now, at my co-author Joe's organization and their pharmacy, they've reached about an 85% implementation level, which is pretty good, even in an environment where patient safety and quality and everything requires a lot of cautiousness about process improvement. I have a friend of mine who works in an emergency department where they've implemented 60 to 70% of their ideas because a lot of the ideas that come in are actually from new residents who are suggesting things that were really supposed to already be in place. So there really wasn't something to implement other than better education for new residents, better communication. In a way, you could call that an improvement, but it wasn't strictly a process improvement. But we should really aim for a very, very high percentage and reject very few ideas. So the last two steps of this process involve documenting and sharing ideas. And there's different formats and approaches for doing this, both printouts and things that can be posted on bulletin boards or things that can be shared electronically in different ways. So this is one format that I've used with a bunch of organizations. One of my clients called it a Kaizen Wall of Fame. And it's just a single page, A4, 8.5 by 11 size piece of paper that kind of summarizes what was the problem, what was implemented, we maybe have a picture showing before and after, what are the benefits. Not a strict ROI, but just in what different ways is this beneficial, and then who was involved. And this is one, I think, key point where suggestion boxes tended to focus on whose idea was it, where in Kaizen we want to give recognition and celebrate everybody who was involved in either initiating, testing, or evaluating an idea. And you can see this case from a hospital laboratory. You've got 4 people listed on that documented Kaizen improvement. And so here in that hospital, they have a bulletin board. This is their wall of fame. And you can see how it's full of different process improvements by staff members in different roles and different levels. They have the binders showing ideas from past years. And then they also keep these electronically on a shared drive for people to see, which is just one of the electronic methods that some organizations will use. And people will actually walk by this wall of fame, let's say, from microbiology, and if they see an idea from the core lab that they can borrow and take to their part of the lab, they'll do that. People will actually stop and read, as they'll often do with the idea board. They'll look and see, what are the new ideas, what do I want to give input on, what do I have a concern about, what would I like to share or build upon. Those are some of the team dynamics that come out from having this being very visual and transparent. At my co-authors organization, they use bulletin boards by the cafeteria where they highlight really interesting or cool Kaizens from throughout the organization. their chief operating officer sends emails out that highlight really interesting Kaizens. And so there's a lot of things we can do to share, and in the process of doing this, give recognition to people who participated in those improvements. Now here's an example. This is from Akron Children's Hospital. Again, kind of in that simple before and after format from a radiology department. They have the problem that these shields for patients were kind of hard to use. It required a lot of Velcro straps, and it was time-consuming and might have caused problems with infection control. The after was that they built basically a simple IV stand that they turned into shielding. And so the effect was that this works better for the patient. It's faster and easier to use, and they were able to basically build this locally instead of having to go and buy something out of a catalog. So it illustrates the lean principle of what we call creativity before capital, not just going and spending money where we don't necessarily have to. Here's an example. Again, this is from Joe's organization, looking at an improvement that helped ensure privacy for mothers of newborns who needed to breastfeed. And there were a number of different Kaizens here, and this is one of them where they found that curtains would often get blown open when people walked by, and so that wasn't good for the mother. The after was just to simply have a couple of small binder clips available to help keep the curtains closed, and an additional Kaizen was to make sure that they were stored right there in that area so that staff didn't have to go run around looking for these clips. And then we can also see examples of clinical improvement. This is from an emergency department where part of the problem in there before was that residents weren't ordering radiology sets properly. And part of the after was to improve the communication and training and collaboration with radiology to help make sure correct orders were being placed in right away. So in the healthcare settings, we see everything ranging from little things, non-clinical things like rearranging chairs in a nurse's station to really looking at clinical workflow and applying Kaizen to all of those different situations. So we ask, what can we do as leaders? And I think whether we're a frontline supervisor or a CEO, we certainly have to do more than print up a bunch of idea cards or put up a bulletin board or set up a database for sharing ideas. That we need to do a number of things. We need to ask for Kaizen. So we need to ask people to participate. We need to tell them and remind them that their ideas are valuable, but then we also have to create time. We have to do more than just say, go make improvement. We have to create an environment where they can do that. And then regardless of our level, we can lead by example and participate. Being the type of lean leader who coaches and mentors, go to the Gemba, work with people, teach them good problem-solving practices, and then recognize and celebrate Kaizen improvements, whether that's through small on-the-spot hospital gift certificates, drawings, reward banquets at the end of the year. My co-authors organization does an annual Kaizen award ceremony. There's all sorts of things we can do, and recognition often is more valued than formal rewards in terms of financial rewards to employees. So I just want to wrap up with a little bit of data from organizations we've highlighted in our book that have embraced Kaizen and continuous improvement. So Goshen Hospital in Indiana is one of them. Now, this is about 10 years into their Kaizen program. Their CEO challenged staff, and this was during the financial crisis, to generate $3.5 million savings in 2009. Now, this probably isn't the way you would kick off a brand new Kaizen program, because this might seem like the focus was just too much on dollars and cents. But they had already had this culture in place, and the CEO is a character, and he promised to shave his head if they hit that target. Well, sure enough, everyone rallied together, and they delivered more than $7 million in savings, and again, nearly as much in 2010. And they've had more than $30 million in savings since 1998. But I think the cultural piece is key, where they've had no layoffs for 17 years. That's an important part of their lean and improvement culture. They're on the Modern Healthcare Best Workplaces list, and that's one of the reasons the CEO can challenge them and say, look, we all need to work together to get out of this financial situation that we're in addition to improving quality and all these other factors. Baptist Healthcare in Florida, you can see, has generated 50,000 improvement ideas since 2000. A lot of people would say it's not even possible to come up with that many ideas, but they're there if you look for them. And again, culturally, They're on, this time, the Fortune magazine Best Places to Work list. If we look at Franciscan, my co-author's organization, this is some of their financial impact that they've added up over time. Now, they don't try to calculate a cost savings for every single improvement. They've got thresholds where if they think the savings is above a certain level, they'll give it a review in their central Kaizen office, or they'll have their finance team get involved. So hard savings that accounting will sign off on in the year 2010 was $1.7 million. In addition to that, they estimate there was about $1.3 million in soft savings that are real, time savings and other capacity freed up that doesn't directly go to the bottom line, but it's there. It has an impact. And so by focusing on staff satisfaction, patient satisfaction, quality, and service, they are ending up with this financial impact as an end result. You can see the number of Kaizens that they've implemented each year. Last year they were at about 1 per FTE, but they only had, as you see in this next chart, about 36% of their staff actually participated. So you can see it's skewed. Of the 36% who participated, they did on average 3 Kaizens per person. Longer term, they'd like to see people doing 1 Kaizen per month all throughout the organization. And so even 4 or 5 years into this program, they're making great progress, but they still see opportunities for expanding the adoption of Kaizen to other departments and with other staff members who haven't yet embraced the idea of this. Then the last piece of data I want to share, this is from Children's Medical Center Dallas. They've shared this data looking at before and after staff engagement scores. It was called Before Lean and 12 months in. And a big part of their first 12 months of Lean were things like were daily Lean management practices. Team huddles, their Kaizen system, looking at daily performance measures to see what kind of service they were providing for patients and using those measures to help drive Kaizen. We can see all of their scores, and I've just picked a few of them, but all of their scores on the survey went up, including things like, I feel more secure in my job, that stress at work is more manageable, and that generally they were more satisfied with this as a place to work in because of the Kaizen program and other basic Lean management systems. And one of the staff members there said this, real quote, "This is the best thing we've done in my 20 years. We're finally fixing things." Now, there's been, in the 20 years before the Kaizen program, there had been no shortage of different approaches they had tried. There were attempts, but I think a big part of the difference comes back to these Kaizen principles of engaging people in improvement, helping them identify problems that matter to them, and engaging them in identifying and implementing improvements. Those are the kinds of changes that people like and that we can get people really excited about for the benefit of the staff and for the patients and for the hospital system itself.